Good evening, students. Last time I was talking to you about prostate gland, and I had covered up, anatomy and physiology and hormonal status of the prostate gland. And before I proceed further with mechanism of bladder outlet obstruction or bladder outflow obstruction, and how do we assess a person with lower urinary tract symptoms or the symptoms of bladder outlet or bladder outflow obstruction, and the treatment of lower urinary tract symptoms which arise out of bladder outflow obstruction. So for a revision, let's get back. Last time I told you just one or two sentences that prostate is divided into periurethral transition zone, and this zone is responsible for the enlargement of the prostate, which pushes the peripheral portion of the prostate gland towards periphery, making a false capsule. Then there is a central zone which is above the ejaculatory ducts. So with these words, I would like to say that whenever there is a bladder outflow obstruction due to prostatic enlargement in elderly people, prostate does enlarge in elderly people. It is one of the parts of life, parts of aging, and most of the cases. So the patient presents to you with certain clinical features, and these clinical features are because of, number one is due to voiding, and secondly it is due to storage of urine. Whenever a large amount of urine is stored in the bladder, because a person is not able to void the entire amount of urine from the bladder, because there is obstruction to the outflow of urine because of prostatic enlargement. So there are the symptoms which arise out of the storage, and whenever there is a large amount of urine which is stored in the bladder, the person may have chronic retention, the enlargement of the urinary bladder, the detritus become weak, and the contractions are not strong enough to expel the urine, and there is a rise in intramural pressure also within the bladder wall. So therefore, in such a situation, what will happen is the intramural pressure rises, there is a raised intravesical pressure, and there is a physiological obstruction to the outflow of urine from the ureteric orifice also, and therefore because of these changes there is outflow obstruction, and there is intramural tension which has risen high. So the person may get hydroureter, hydronephrosis, and subsequent there may be renal damage also. But I was talking to you the features which arise out of the storage of urine in the urinary bladder because of obstruction to the outflow of urine. So when a person has large amount of urine, naturally a person who has a large amount of urine which is lying in the bladder, the person will have desire to pass urine frequently. So there is increased frequency of maturation. The person keeps on going to the washroom day in and day out during days and nights. There may be diurnal variation, and particularly during nights he has to get up so many times, 3 times, 4 times, 5, 6, 7, even every hour he would like to go to ease himself, and there is a large amount of urine in the bladder. The person may have urgency, or he has to rush to the washroom, otherwise he fears that he might wet his clothes. Besides this frequency and nocturia and urgency, he has urge incontinence, and not only that, he may pass a little bit of urine when sleep also. Then there are symptoms which arise out of voiding. That person's bladder is full and he wants to pass urine. And the moment he wants to pass urine, he is unable to start the act of maturation. He has to wait for some time, and he is waiting, the urine is not coming out. So this is called hesitancy. This particular feature, when there is a delay in the passage of urine, and the bladder is full and person is unable to initiate the act of maturation, this is called hesitancy. And when he passes urine, there is a bladder outlet obstruction. This urinary stream is thin. It is a poor stream which is not helped even by straining. It tries to use abdominal pressure, but the stream does not improve. And this act of maturation is quite delayed. He is not satisfied. And with this, he has got some kind of a desire and a feeling of incomplete evacuation of the bladder. Then, the person he's passing urine, suddenly, abruptly, the urinary stream stops. This is called intermittency. And then, person may, because this kind of a life, which is bothering his life, his activities, he's not comfortable. These are called bothersome symptoms. He's got intense desire to pass urine, and is going repeatedly every hour. Frequently is going to the washroom. He is unable to focus on his job. This is called bothersome symptoms and bothersome symptoms. It is bothering him. He may be executive or something like that. He cannot get up from the meeting and go to toilet again and again. These are called bothersome symptoms, and this requires attention. And all these symptoms, clubbed together, they are called lower urinary tract symptoms. Lower urinary tract symptoms, LUTS, which is a substitute in the old terminology which was to be called prostatism. Now, this kind of thing which I am talking to you is bladder outflow obstruction. May not be because of prostatic enlargement, benign prostatic hyperplasia. It may be because of certain other features also. There may be some neurological problems with the patient. He may have diabetes. He may be having, teres dorsalis, multiple sclerosis. He might have had stroke. There may be, even poor detrusor contraction. And there may be, degeneration of the muscles. Person may have detrusor instability also. So therefore, one should be clear in mind that this kind of a thing, the features, symptomatology of bladder outlet obstruction, bladder outflow obstruction, because of prostatic enlargement and because of these features which I have told you, must be clearly demarcated by pressure flow studies. Because in large prostate, if you happen to operate upon a person without keeping in mind the other features of bladder outlet obstruction, like which I have just told you, neurological problems, patient will never improve. His symptomatology would remain the same. So we got to be very, very clear. And what are these things? What are these things which may be confused with bladder outflow obstruction due to prostatic enlargement? First is the benign prostatic hyperplasia itself. And person may be having bladder neck stenosis. There may be hypertrophy of the muscles at the bladder neck, thirdly. Fourthly, a person may be having prostatic cancer, no doubt about it. And a person might have urethral stricture. The stricture urethra too will cause the bladder outflow obstruction. And then I'm talking to you, I'm saying finally that a person with bladder outlet obstruction may be having these symptomatology because of neuropathic conditions. So therefore, these symptoms which I have told you are non-specific. You have to clearly distinguish the causative factor in bladder outlet obstruction. And even a person, let me tell you that we demarcate the typical features of bladder outflow obstruction because of prostatic enlargement will have very severe irritating symptoms. Very severe irritating symptoms. Just I have explained to you what these are. The flow rate will be poor. So in case the flow rate of a person for 150 to 200 ml of voided urine is more than 15 ml per second, that is considered as a kind of a normal. We can wait and watch. Till further assessment, we can wait for treatment for the prostatic enlargement, provided the person's flow rate of urine is more than 15 ml per second for 200 ml of voided urine. If the flow rate is between 10 ml to 15 ml, it is equivocal. All right, plus minus. But if the flow rate of urine in bladder outflow obstruction is less than 10 ml per second, it requires attention. Person may require medical therapy. Person may require surgery, which we'll discuss later on in the next lecture. So what I mean to say is that we have to keep in mind and picture the flow rate of a person on multiple settings. Now a person who's having bladder outlet obstruction, what will happen? He's not able to evacuate his urine. There are some deleterious and side effects and problems with this. So what happens is ultimately a state will come when the bladder wall will become decompensated, and the detrusor, the muscles of the urinary bladder, they will become progressively inefficient and weak, resulting in a residual urine. The urine will be left behind because detrusor, the urinary bladder muscle, the contractions are not strong enough to evacuate urine from the bladder because of resistance given by enlarged prostate. And you know that prostate surrounds the prostatic urethra. And I've already told you last time that prostate, urethra is lengthened and there is a increase in acute angulation of the prostatic urethra. And once the bladder starts becoming full of urine, patient will go into chronic retention, and bladder wall may become irritable. So as a result, what can happen is a person with a benign prostatic hyperplasia, outflow obstruction, may go into acute retention of the urine. He is not able to pass urine at all. There is a tension. And as a result, the person will have intense desire to pass urine, and hypogastrium. There will be a palpable, tender, distended urinary bladder. And this kind of thing can happen in elderly people once he is exposed. Due to certain reasons, the person is not able to pass urine and he postpones the act of maturation. A person has taken quite a number of strip drinks and something like beer. He is over already. He's taken excess amount of fluids. Or, there is some kind of you can say, what you call that person has been exposed to cold weather, or we may have some kind of a intercurrent illness. So a person will have, in another situation, small amounts of urine is being passed, and gradually and over period of time, the bladder becomes distended, and a person is having very large amount of urine. To the extent it has been seen that some people have 1000 ml of urine in their bladder. The bladder is distended and it's right up to epigastrium and umbilicus even. And when there is a chronic retention of the urine, the person may have residual urine, whatever you call is more than 250 ml, which is quite significant. And because of tension in the bladder wall, there is back pressure changes, and once there is a hydronephrosis, the renal tubules are damaged, and renal tubules no more absorb fluid and electrolytes, and therefore person may go into some kind of a dehydration, electrolyte imbalance as well. So with these features, what happens is the patient may go into uremia since the renal tubules are damaged. One of the side effects is anemia. And with this kind of situation, when there is a chronic retention, there is an increase in the tension of the bladder wall because of increase in pressure. If the pressure increases more than 80 centimeter of water, that means it is a high pressure. And the pressure is between 60 to 80 centimeter of water inside, that is, equivocal, and less than 60 centimeter of water is acceptable. So with the chronic retention, the pressure inside, intramural tension and pressure inside will increase, and therefore a person may have all these symptoms which I was talking to you. He may have overflowing continence, the person is coughing and he wets his trousers, he may pass urine, there is enuresis, and there is renal insufficiency. So as a result of this increase in tension, the muscle bundles, they are hypertrophied. Once they get hypertrophy, bladder is distended, there are small saccule sacs, mucosa, there are the depressions within the bladder wall because of enlargement, gross enlargement of the urinary bladder wall, and muscle bundles separate the bladder wall into saccules. This is called trabeculation. Once you see the muscle bundles, they look like irregularly fashioned muscle bundles, trabeculation. And within these trabeculations, you find some small sacs or depressions, which is called sacculation. And finally, because the bladder wall becomes weak, so mucosa, protrudes out. This is called diverticulosis. And what happens then is, next is, there may be urinary stasis. Once there is a urinary stasis, is the ground for urinary infection, stone formation. So therefore, a person has got urinary tract infection. Once there is urinary tract infection, the stone formation is there, the person may start having pain. Another feature of this problem is that person may have haematuria also, because once the prostate is enlarged, there is congestion in the vesical plexus, and the person may start having haematuria. Now, with these kind of features, there is a bladder outlet obstruction and symptomatology, which I have already told you. With poor flow rates and high intramural and intravesical pressure, it calls for some kind of attention. You cannot ignore such a person. So therefore, how do we start? First of all is the history. We have to take the history from the patient. What is this problem? And we have got international prostate score system, which is called IPSS, International Prostate Symptom Score. In this, we observe what is the lifestyle, what is the quality of life, what is bothering him. We'll also ask him how much urine is passing in one sitting, what is the frequency and how much is the volume. The person has to write down. He has passed urine 6 times, 7 times. First time he passed 20 ml, second time he was unable to pass urine 30 ml. So he has to maintain a diary in which he notes down how many times he has gone to pass urine in 24 hours and how much urine he has passed, how much fluid he has taken, how much urine he has passed during daytime, and how much urine he has passed during nights. So all this would be covered under International Prostate Score System. And we have, what we do is, I'll come back to the fact that what is the next in examination? We have to offer him a general physical examination. As you know, what all we see in general physical examination, how much is nutritional status, how are his hair functions, what is his state of hydration, is he anemic, is he having pallor, is he having edema. So therefore, what we do is that a general physical examination, particularly we have to see his state of hydration. A person who is having enlarged prostate, is in chronic retention, who is in renal failure, his appearance will be a little different, and he will be having anemia also. Now we have to offer an abdominal examination. Once you do the abdominal examination, the bladder is distended chronically. You palpate you percuss the abdomen, you will find distended bladder, the dull note. The suprapubic crease is distorted. An acute retention in any way, there is a palpable tender swelling in the midline. So thereafter, once you offer a general examination, please see his genitalia, that you exclude any phimosis or any stricture of the urethra, and you examine the epididymis also to exclude any kind of inflammation or infection. Now, the hallmark of, one person comes to you, any person who is coming to you with lower urinary tract symptoms, it is mandatory for a surgeon or in a medical officer or a general practitioner that please, for God's sake, do not forget or exclude digital rectal examination. What did I say? Digital rectal examination. Prostate is very much accessible with a finger. You put on the gloves, apply some kind of lubricant. It should be a painless affair, and you feel the prostate in front. Okay, once you do the digital rectal examination, you feel the prostate. In young persons, the prostate is smaller in size. It is elastic, not firm. You put your finger back, it springs back. There is elasticity. But with age, the prostate, there are various grades of prostatic enlargement. They are not so specific. Grade 1, grade 2, grade 3, and things like that. I will not go into those kind of details. What I would say is, when the prostate enlarges, it is firm, it is convex, and depending upon, it is elastic also. But in case there is increase in fibrous tissue, it will be firm. You can feel the median sulcus and the groups laterally. So therefore, these are the features. So digital rectal examination to a very large extent can exclude, because you can feel malignancy of the prostate, carcinoma of the prostate, by digital rectal examination. People have done mistakes. Person comes and you keep on writing medicines and things like that, but people have forgotten to do the digital rectal examination. In carcinoma of the prostate, it is hard. There may be nodule. The mucosa may not be free. Mucosa of the prostate gland, the rectal mucosa, you will not be having that kind of feeling in normal, mucosa. Your sulcus and groups will be obliterated. Okay, so digital rectal examination is very, very important. Person who has got a full bladder, the prostate gland may be pushed down below. It may be pushed down because of bladder is full. And there is a fluctuant swelling which you can feel. Besides this, you have to examine the person's, I have told you, general physical examination. You see for the pallor, you see for the edema, you examine his lungs also, you examine his heart also. You see the state of hydration. General physical examination means everything. There's a build, the nourishment, there's pulse rate, vital parameters like blood pressure, and anemia, cyanosis, jaundice, edema, lymphadenopathy, and all those things go with it. Peripheral pulsations, and most important in such cases, you have to assess him for any problem with his nervous system, that he should please screen him for any features of diabetes, tabes dorsalis, disseminated sclerosis, spondylosis, Parkinson's disease, stroke, and so many kind of these things, so that the patient does not suffer ultimately. That such persons who have neurological deficit, who have a mental retardation, the treatment for such kind of patients with bladder outlet obstruction is entirely different. Then comes, and the assessment I am talking to you is this prostate specific antigen, PSA. Now, before you do the PSA, prostate specific antigen, this is done basically, it's neither sensitive nor specific. It is basically, it will tell you, it is a tumor marker. The normal PSA level is, up to 4 nanomoles per liter or 4 nanograms per ml. So, if you find the PSA level is more than 4 nanomoles per liter, then a person might have to be subjected to transrectal ultrasound. In transrectal ultrasound, if a person is having hyposonic shadows hypoechoic shadows in the prostate gland. So that means signifies that person may be having carcinoma of the prostate. Transrectal ultrasound. Otherwise, percutaneous ultrasound will also give you a fairly good idea whether the person is having prostatic enlargement. It will also give ultrasound will give you, or percutaneous ultrasound will give you an assessment about post-wording residual urine. You do the ultrasound, you see the size of the prostate, you see the amount of urine in the bladder. Then he is asked to go to the washroom, he evacuates himself, he passes urine, he comes back. Then we see how much urine is left. That is called post-wording residual urine. If you find that the 400 ml of urine still left inside, it is significant. That means he has got persistent and very significant amount of, this bladder outflow obstruction. But in case he has got, say, less than 100 ml of post-wording residual urine, we can wait and watch, and he can be, offered some other kind of management. The management will differ in such cases. So what I am talking to you is PSA is raised. It can set alarm bells in the mind of a patient. So therefore you should do it. But then to subject a person to PSA level who has got benign enlargement of the prostate is also not understandable. But at the same time, the doctor and surgeon these days must keep themselves safe. It may involve some kind of a litigation that, look, I had gone to the doctor with these features, he should have understand the carcinoma of prostate can cause bladder outflow obstruction, and he did not do my PSA, and so I'll sue him for so much of money. So it's one of the reasons. Yes, of course, the elderly person is coming. By and large, elderly people are, I don't think they are so greedy or something like that, and they will understand the pros and cons of doing PSA or not doing it. So therefore, but still, to be on safer side, kindly offer him a prostate-specific antigen as a baseline investigation. Now, what we should do is, I have already told you that you have to do flow rate measurements at least on 3 sittings. And in each sitting, the patient must pass minimum 150 to 100 ml of urine. And then see, a person, you subject him to flow rate measurements. But I can tell you, suggest you, simple thing, that you take some kind of a bottle which can measure the amount of urine, and by your seconds watch, what you do, you ask the patient to pass urine of his full bladder, then measure how much amount of urine he has passed and see in how much time. The volume of urine he has passed in the number of seconds, you can divide that volume by the seconds, and that will give you in some rough, a simple measurement of urine flow rate. I have already told you that in case the flow rate for 200 or 150 ml of voided urine is less than 10 ml per second, it is significant bladder outflow obstruction. 10 to 15 ml per second is equivocal, and more than 15 ml per second of voided urine. For 200 ml of voided urine is, you can wait and watch. You can have a nice talk to the patient, make him understand, okay, you restrict your fluids at night, drink less, go for a walk or something like that, take less caffeine or tea or things like that. These are the measures anyway. So this is good. Then you can do the pressure flow studies also. In pressure flow studies, what happens is that you have to see these features, what I have already told you. These studies are conducted to exclude central nervous system lesions like diabetes and Parkinson's disease and stroke, and you have to also keep in mind these irritating symptoms, severe symptoms like due to urgency and frequency. Any person who comes to you with bladder outlet obstruction, bladder outflow obstruction, benign prostatic hyperplasia, you have already done digital rectal examination, you find prostate is enlarged. The upper limit of the prostate cannot be reached. Alright, it's bulky, it's firm. So therefore, you can expect the person may have chronic retention of the urine, and he may have hydroureter, there may be reflux of urine, there may be kidney damage also. So what test you do? You will do serum electrolytes, serum creatinine levels, and hemoglobin levels also. Besides CBC and other things also you can do. It is mandatory, elderly person is to offer him one time. Assess him for his, glucose status. Offer him an ECG. Ask for an X-ray chest, right? Then comes your urine examination. Is a very versatile investigation. Once you do the urine examination, what is going to tell you? You can see the RBCs in the urine. Generally, a person with benign enlargement of the prostate does not have hematuria. Hematuria may be gross hematuria, where? And the prostatic enlargement, if there is acute retention of the urine, there is large amount of urine due to chronic retention, 1000 ml. You put a catheter, the patient passes large amount of urine. He is losing salts and fluids, so they will go into dehydration. And once it collapses, its patient starts bleeding. So a person, you must offer urine routine examination for a man who has got bladder outflow obstruction. So urine will tell you, is he passing, has he got glycosuria? You exclude the diabetes by simple investigation. Of course, you have to do the blood sugar levels in case blood sugar is high, no doubt. You expect elderly person, of course. One of the reasons for type 2 diabetes is maturity onset, or it is one of the features of age. The person is more prone to diabetes in the elderly age group. So what you see is that what you do, see for glucose in the urine, see for pus cells, see for ketone bodies, if any, and cytology. Person may having some kind of malignancy in the urinary bladder, so it serves so many functions. And because of stasis of the urine might cause infection, so therefore you have to send the urine for culture and sensitivity also. With these features, there's nothing wrong about subjecting a person to imaging of the upper tract, like intravenous urography if urea is not raised, and ultrasonography will give you a very good picture. This patient should not be denied. The person has got bladder outflow obstruction and you tell him the ultrasound is not required, or that is not understandable. So this imaging has to be there. Once you find person has got these distressing symptoms, flow rate is low, he has got botheration, he has got bothersome symptoms, person deserves and qualifies to be undertaken for surgery or whatever conservative management and things like that. So before, please, you cannot straight away go in for surgery for prostatectomy and things like that. Large prostate, prostatectomy, we'll discuss it out later in next lecture about surgical aspects. So person should be subjected to cystourethroscopy. Cystourethroscopy is done just because you should see the urethra. I hope there is no stricture. You should see the bladder urothelium. Hope there is not some kind of a reducent stone inside the bladder. Hope that there is no malignancy of the urinary bladder. The person must be subjected to urethrocytoscopy. Now let us see how do we go about management of these cases. Who are the persons who qualify for surgery? Who are the persons who require prostatectomy? May require prostatectomy. Number one, please take the symptomatology of an elderly person with sympathy. Because when a person is young, he may not realize the problem of elderly person. He should not be considered as a wasted human life and can be dispensed away with and left to his miseries and to his bad luck and God's will. Please be sympathetic and compassionate. Take his life as seriously as you will take for any other person, irrespective of the age. So offer him a reassurance. That's all. A person should be able to and will able to face his miseries, pain, discomfort, bother, with love and compassion, where genuinely you should be sympathetic. But these money matters are trapped in our profession, which I personally have never reconciled to. I'm telling you, when my father was doing this kind of practice, he spent long times. 50% of the people never paid him, and he never asked for it. He never asked. Never I used to help him out. I had never seen when a person says, see the person here, I diagnosed, made notes, and this thing. So every time person will ask how much, sir, he said, just leave it, it's okay. So what I mean to say, these days in our profession, this kind of a culture, I don't know where from it has come. Well, now this is money, insurance, and things like that going on, and I don't know. It's a very serious matter when a person like us, is thinking that a person has come to with his disease and pain or sufferings, and we consider it as a good tool for us to make money. Of course, doctor doesn't have to live on fresh water and air. He has to live. He has got a wife. He has got children. He has so many priorities and necessities of life. But what I mean to say is, please excuse greed from this profession. What is due to you, what you deserve, take less than that. Even now, I happen to see some patients and things like that. I always try that the institute charges money what is written over, less than that. So it is very painful when we examine a patient. I examine a person, and to ask money from me, I don't know. So that is why I will request that a person who has become a doctor, he must find some kind of an alternative method to enrich himself and do the medical profession just sheer out of interest, dedication, and service. Really, I'm not joking. I'm telling you to give intense pleasure. Please find other means. No, this is such a noble profession. There are so many people, hawala operators and things. I shouldn't introduce these subjects, like that. They are making money by unfair means. But how does a doctor survive? He has to accept money. And people, in the heart of hearts, those people think when he's charging money, he thinks doctor is charging money for our misery and pain. Anyway, I'm talking to you, bladder outflow obstruction, that a person who goes into acute retention, because as I have already told you, he is a candidate for surgery. Number two, a person who is having chronic retention of the urine and he has got more than 200, 250 ml of urine, more than 100 ml of urine with distressing symptoms, he is a candidate for surgery. A person who has got hydronephrosis is a candidate for surgery just because of bladder outlet obstruction. A person who is starting having haematuria, who is having pain, is a candidate for surgery. A person who is bothered day and night is a candidate for surgery. And let me tell you, a person who has got urine flow rate, again I will say less than 10 ml per second for 200 ml of voided urine, is a candidate for surgery. A person who has poor stream is a candidate for surgery. A person who is going to the bathroom and toilet every half an hour is a candidate for surgery. This is bothering him. So what I mean to say is, if a person comes to you with acute retention of the urine, first and foremost thing what you do is examining and catheterize him, and possibly, you give a trial of medicines also that we will discuss just now. But a person who's unfit should not be offered surgery. Okay. If a person has got dementia, then you can put some kind of a stent inside. And a person who has got distension, there's a dementia, so there are indwelling stents for the prostatic urethra. Okay, but the person has to be stabilized. Now, next I would like to say is, when a person has got chronic distension, 1000 ml of urine, the decompression of the bladder by catheterization should be gradual and slow. But once a person passes a large amount of urine, say a liter of urine, so along with it he is passing electrolytes and fluid and may go into, I shouldn't say that he'll go into shock, but he'll definitely go into some kind of a dehydration. So there be watchful about it, and patient must be given IV fluids, and he may be anemic, so he might require even blood transfusion if his hemoglobin level is low. So let us see, I have already discussed with you, please mark in mind that any person who has got bothersome symptoms, intense symptoms, ultrasonography, you have seen that more than 200 ml of urine is there, 200, 250 ml of urine is there. Digital rectal examination shows prostatic enlargement. Patient has got features of uremia and patient is in distress. The life has become uncomfortable, so therefore offer him some kind of a treatment, whether it's a medical treatment or a surgical treatment. Now, sometimes what happens is that a person has got a very, flow rate is, the maximum flow rate is say 10 ml per second. 10 ml per second, but when you do the ultrasound, you find that there's hardly any post-voiding residual urine. I am saying that person has lower urinary tract symptoms. Alright, so in such patients we can wait for some time, assess him after 6 months, and if required then he can be offered. Now before we discuss surgery, we have got something like conservative management, which is very effective, we have seen. Firstly is 2 drugs are combined together. 2 drugs. One is alpha blockers. Alpha blockers will cause relaxation of the muscles of the bladder neck and the prostate, both. Alpha blockers. I will not name the medicines because for obvious reasons. That in the conservative management, say person has got these films, are difficult in passing urine, the residual urine is less than 100 ml of 100 ml, the post-voiding residual urine is less than 100 ml, prostate is moderately enlarged, he does not have features of complications, he is passing urine at night, so he has got nocturia 2 or 3 times, so we can offer him a conservative treatment in the form of alpha blocks, which will relax the bladder neck and the prostatic muscles. And second is 5-alpha reductase inhibitors. 5-alpha reductase inhibitors. You see that testosterone is converted into 1,5-dihydrotestosterone by alpha reductase. So you give inhibitors and stop, almost inhibit the formation of dihydrotestosterone, 1,5-dihydrotestosterone. So you give that alpha blockers and 5-alpha reductase inhibitors. So if you give these medicines, at night time it is given because of partial hypotension. So it is given, at night time when before the patient goes to the bed. If you give it for 1 year, remember this is my right hand. I am in selfie mode. So this is my right hand, this is my left hand. So it is the other way around. So anyway, so after you have exhibited these medicines for 1 year, the prostate size will shrink by 25% in a year. And the flow rate may also improve. The urine flow rate may improve to the extent, say about 2 ml per second or so. But if a person is offered surgery like TURP or so, the relief of symptoms occurs in 75% of patients, and urine flow improves from 9 to 18 ml per second. So these drugs should be tried. We may not jump for surgery and person may have a good amount of relief, and if we can carry on with that, this man is unlikely to go in for acute retention subsequently. But if a person who is untreated, not cared for, person may go into a misery of acute retention of the urine because of enlarged prostate, particularly in countries which have cold climates, and you take a large amount of beer, or there's a forced retention of the urine, things like that. Summarize, I would like to say is that benign prostatic hyperplasia is one of the causes of lower urinary tract symptoms, which are to be, separated, excluded from other causes of prostatism. Like I've already told you, there's a detrusor instability, weakness of the detrusor muscles, neurological disorders, diabetes, Parkinsonism, and things like that. With these words, thank you very much, and next time I'm going to talk to you the surgical aspect of enlarged prostate. Enlarged prostate, you have to exclude that whether it's a benign or malignant. Carcinoma of the prostate itself is a separate topic. Thank you very much.